Okay, so let's introduce to you, I mentioned, if you were here earlier, our speakers. And we will start by introducing one of our speakers. We have Professor Mahmood Sani. Professor Mahmood Sani is a professor who received his medical degree in 1993 from the Ahmadu Bello University in Zaria. He completed his internal medicine and cardiology residency in 2002 and won the SF Kuku Prize for the Best Graduating Fellow at the West African College of Physicians for that same year. He obtained his PhD in medicine from University of Cape Town in South Africa, and he was promoted to Professor of Medicine by the Bayero University in Kano in 2013. He was the head of Department of Medicine, BUK, and Deputy Provost, College of Health Sciences, Dean Faculty of Clinical Sciences, and Council Member, Nigerian Cardiac Society. He's currently the Deputy Vice Chancellor, Management Services, Bayero University in Kano. He's the Vice President of the Nigerian Cardiac Society and the Chair of the Pan-African Society of Cardiology Task Force on Research and Training, and is an examiner of the West African College of Physicians. He has been an examiner since 2008. He's a World Heart Federation Emerging Leader from 2015. He has supervised and mentored 12 fellows and 3 PhDs. He has served as a principal investigator in 14 multi-center clinical trials, registries, and some of which are NIH funded. His areas of interest include heart failure, echocardiography, cardiovascular epidemiology, and cardiovascular disease in HIV. He has published over 110 peer-reviewed scientific papers, including co-authorship of manuscripts in the New England Journal of Medicine, the Lancet Circulation, Heart, European Heart Journal, and European Journal of Heart Failure, amongst others. Please give a warm welcome to Professor Mahmood Sani. So please put a thumbs up for Professor Mahmood Sani. I will also be introducing another speaker that we have. We have Dr. Kufo Ossi. Dr. Kufo Ossi is a public health professional committed and passionate about improving access to quality healthcare for the underserved and less privileged in society. He has 10 years of experience designing and implementing public health programs spanning different areas of interest. He currently works as a technical officer, cardiovascular health, Resolve to Save Lives, Nigeria Country Office. He supports governments and multiple relevant stakeholders to reduce the burden of NCDs, focusing on cardiovascular diseases by improving population blood pressure control. He works with stakeholders to foster an enabling environment for nationwide scale-up of hypertension treatment services through decentralization of treatment, enabling tax sharing, and team-based care. He also coordinates the implementation of a pilot project seeking to integrate hypertension diagnosis, care, and treatment in HIV service delivery systems. The project aims to optimize hypertension treatment outcomes amongst PLWH. Let us also give a warm welcome to Dr. Kufo Ossi. So please put a thumbs up for Dr. Kufo Ossi. And to the lady of the day as well, we are happy to introduce Professor Amam Chinyere Mbakwem. She's a professor of medicine at University of Lagos and a consultant cardiologist to the Lagos University Teaching Hospital. She received her fellowship training at the Lagos University Teaching Hospital, which came up to having an award of the Fellowship of the West African College of Physicians in 1997. She also she had a clinical attachment at the Wolfson Heart Institute, Tel Aviv in Israel in 1999, before undergoing a training in medical education at the Firmar Institute in Philadelphia, USA, which earned her a fellowship in medical Education in 2009. She's the Vice President, West Africa Region of the Pan-African Society of Cardiology and a board member of the World Heart Federation. She's the immediate past president of the Nigerian Cardiac Society, where she has previously been treasurer and vice president. She's a member of the European Society of Cardiology working group in peripartum cardiomyopathy. Please pardon these tongue twisters, and cardio-oncology. Professor Mbakwe's research interests includes heart failure, systemic and pulmonary hypertension, heart disease in women, effective communication in disease management, and the psychosocial issues in cardiovascular diseases. She's a member of the Nigerian Hypertension Society Guidelines Writing Committee. So when I was telling you that we have seasoned experts on the call, I was not kidding. Professor Mbakwem has over 80 publications in national and international journals and contributed chapters to 2 book publications. So please, a round of applause and a thumbs up for Professor Mbakwem. And so for today, we will start off with 2 of our speakers who will be taking us through the didactic on guidelines-based treatment protocol and combination therapy, highlighting resistant hypertension. We will start off with Dr. Kufo Ossi, and then very quickly after him, we will have Professor Mahmood Sani. Over to you, Dr. Ossi.
So thank you very much. Thank you, Adora, for the warm introductions. And I also want to express appreciation to the organizers for having me, and also for Prof for allowing me to go first. So I think we can move ahead, DJ. So yes, so I'll be taking the first part of today's presentation, which will be looking at guideline combination therapy, highlighting combination therapy treatment and the treatment protocol highlighting resistant hypertension. So this is going to be the outline. We'll talk about what a treatment guideline and protocol is. We'll also delve deeper into the Nigerian hypertension treatment protocol. And then we'll also talk about the combination treatment for hypertension. What are the rationale and indications for combination treatment in the hypertension care and treatment? And then we'll touch light resistant hypertension, how to identify and manage it. And finally, we are going to enumerate or touch on some of the conditions for referral in hypertension management. DJ? So we're going to start off with what is a treatment guideline and what is a protocol. We're trying to look at the differences between a treatment guideline and a treatment protocol. So again, treatment guidelines are systematically developed statements designed to assist practitioners and patients in making decisions about appropriate healthcare for specific clinical circumstances. So the thing you need to note about treatment guidelines is that they are very broad. Sometimes you can have very huge treatment guidelines made up of as many as 100 pages, 40, 60 pages, depending on the content of the treatment guideline. So you have a whole lot of experts. So for example, hypertension treatment guideline, you have cardiology experts, you have all the experts, they gather together in the room and they examine all the evidence. After examination of the evidence, that is evaluated, and of course they can decide to use different systems. I know the most common and most popular is the grade system, where you have to say, oh, is it a strong recommendation? Is it moderate? Is it a mild or low recommendation? The strength of the recommendation. But the thing to note is that for treatment guidelines, these are systematically developed statements. The evidence has been assessed and graded, and then they provide guidance to practitioners on treatment of specific conditions. The other thing to note about treatment protocols is there are detailed plans. So while treatment guidelines are usually broad and comprehensive, treatment protocols are very detailed. They are not as broad and they are not comprehensive. Plans that specify steps to be followed in defined situations. So as we go further, we're going to see that for treatment guideline, it's broad, it touches a whole range of conditions, but for treatment protocol, it's very specific. It tells you what to do for specific conditions. Another key difference is that it usually defines the what, who, when, and where. So it tells you who does what to do in those specific situations, when do you do or implement those actions, and where those actions can take place. DJ, please. So on the screen, you can see there are 2 treatment protocols. One is a protocol that has been adapted or pulled out from a treatment guideline, and the protocol on your right is a specific treatment protocol. So just to reiterate, treatment guidelines enable flexibility because they provide multiple options and pathways for managing a condition. So in a treatment guideline, say, for example, that talks about management of hypertension, it actually gives you multiple pathways. So if you look at the protocol on the left, which I said has been adapted and just to suit what a guideline contains. You can see that it tells you, oh, if somebody presents with hypertension and the person has type 2 diabetes, this is what you give. It also tells you that if somebody has hypertension without type 2 diabetes, if the person is 55 years and above, this is what you do. If the person is less than 55 years, this is what you do. If the person is even less than 55 years and is a Black African or a Caribbean, this is what you do. So like I was saying, treatment guidelines provide us multiple options. It tells you the different ways you can manage a condition. And another key difference you can see is that for that protocol that's been adapted or pulled out from the guideline, it does not tell you specific medications. It just tells you the classes of the medications. It says, oh, if the person presents with hypertension with type 2 diabetes, give ACE inhibitors, right? It doesn't tell you that, oh, this is the specific medication you can give. It just gives you a broad class of medications. While the thing about treatment protocols is that they are rigid. That's the truth. Guidelines actually enable flexibility, but for treatment protocols, they are rigid because they did not permit flexibility. And then they are more specific in details. The thing about treatment guidelines is treatment guidelines are mainly used by specialists. So you have the physicians, the cardiologists, they have these big bulk treatment guidelines. But for treatment protocols, they can be used by all cadres of healthcare workers. They can be used at the primary healthcare. They can be used by the community health extension worker. They can be used by nurses. So going to the right, you can see the treatment protocol on the right. It's specific. It tells you if blood pressure is greater than 140/90, start amlodipine 5 milligrams. So this does not even talk about medication classes. This goes directly and names the specific medication. So the thing is one specific medication, specific dosage, and there's also a point clearly written where you should be able to refer your patient. Please, can we proceed? So what do hypertension treatment guidelines seems to be? What we're really talking about is combination therapy for hypertension. Like I did mention earlier, hypertension guidelines or treatment guidelines are very broad. They are comprehensive. So you have interventions around lifestyle modifications in treatment where you have to be able to counsel the patient on a healthy lifestyle. The fact that the patient has to cut down on alcohol consumption, stop tobacco intake, and all that about reducing salt consumption and healthy eating. It also talks about drug treatment. It gives you the conditions where a patient should be able to commence medications or pharmacological therapy for hypertension. A hypertension treatment guideline also talks about the combination therapies, which is the focus of our discussion for today. There are other things it talks about. So of course, we know that there is uncomplicated hypertension. There's also the hypertensive urgency and emergencies. It tells you what to do. It tells you what are the components of care that you provide for hypertension follow-up and the prognosis. It also talks about the preventive strategies. It tells you what can be done in the community for managing hypertension and what can be done in the facility. And also, of course, we know these days there are also these sociocultural determinants of health. So all these are addressed in the hypertension treatment guideline. So whereas in a treatment protocol, so these are the features and these are some of the differences. So for a treatment protocol, one of the features is clarity. Like we saw earlier in the second slide where we had to talk about the two examples of the protocols that were put side by side. For the treatment protocol, one, the medications are specific. It tells you, oh, you use amlodipine. It tells you use losartan. It tells you use hydrochlorothiazide. So it doesn't just tell you, oh, use ACE inhibitor. So there's clarity. It's quite clear. It's unambiguous. The other thing to note that there's brevity. Brevity simply means it's not long. So for treatment guidelines, you have 50 pages, 60 pages, trying to tell you what to do in different conditions. But for treatment protocol, it's usually a one-pager that you can post on the wall. So that's just it. And very short, one-pager, so at a glance, you can have all the information you need. Again, another thing to note around the treatment protocol is it has specific referral criteria. It tells you the point at which you cannot continue further management of hypertension in that place, because like I said, it's very specific. So it has specific point for you to escalate or refer the patient to a higher level of care. And finally, treatment protocols are usually derived from treatment guidelines. So they are consistent with guidelines. They are usually based and hinged on contemporary and the most recent evidence or best practices. DJ, please. So these are some of the advantages of using treatment protocols versus treatment guidelines. One of the key advantages is that it facilitates team-based care, task shifting, and task sharing. So previously, we know that in country, hypertension treatment only occurs within secondary and tertiary hospitals, and this is really overwhelming for the healthcare workers. So, but with the recent introduction of treatment protocols, it means that hypertension care and treatments, especially for uncomplicated hypertension, can take place at the primary healthcare level. I know we're all familiar with the task shifting and task sharing. With the treatment protocol, task shifting and task sharing can be enabled for hypertension care and management. The other thing to note is that it streamlines training requirements for healthcare workers. So it's easier to train healthcare workers at the primary healthcare level using a simple treatment protocol, because at that point you can say, oh, okay, these are the medications you give. You give amlodipine, you give hydrochlorothiazide, you give losartan. You can tell them about how to identify the side effects and what to do, the appropriate point for escalation or referral to higher levels of care. So it actually simplifies training requirements for healthcare workers. The other thing it does is that it streamlines logistic processes. So if for adventure you want to set up a public health treatment program for hypertension at the primary healthcare level or at the secondary healthcare or any instance where you have to consider treating multitude of hypertension patients, it's easier to use the treatment protocol to procure medications, because using a treatment guideline that just says, oh, if a patient has diabetes, buy this one. If it's less than 55 years old, use this one. But for the treatment protocol, you know the medications you're going to be procuring. So it helps you in your forecasting and quantification. It helps you in your management and your contracting with the suppliers and vendors. The other thing to note is that treatment protocol helps to reduce the treatment cost, because in the long run, it's going to facilitate huge consumption of huge volumes of the protocol medications. And once this happens, automatically the price is reduced. It helps to improve quality of care because it standardizes care across facilities. So if several facilities are using the same treatment protocol, it means that what is expected is that the standard of care at each facility should be the same. It enhances supportive supervision, even for the state level supervisors, the LGA supervisors, because they could develop a checklist based on the medications and based on the routine that has been defined in the treatment protocol. And finally, it helps to improve patient outcomes. This is because protocol medications are chosen using carefully selected criteria. Of course, you have to choose protocol medications with regards to what is the cost and, of course, the minimal side effect profile. TJ, please. So, for example, we are going to dive deeper into the Nigerian hypertension treatment protocol. So on the Nigerian hypertension treatment protocol, there are about 5 steps. Step 1, we say start amlodipine 5 milligram, and then down to step 5, which says you should refer the patient for specialist hypertension management. So there are 3 drug classes in the Nigerian hypertension treatment protocol. There's the calcium channel blockers, there's also the angiotensin receptor blockers, and the thiazide diuretics. So at first step is the calcium channel blocker, which is the amlodipine 5 milligram. At the second step, you have the losartan 50 milligram. That's you add the angiotensin receptor blocker. And at the final step, that's step 4, where you have the thiazide diuretic, that's hydrochlorothiazide. So what are some of the reasons for why amlodipine was chosen as the first-line medication for the Nigerian hypertension treatment protocol? This is because it's a long-acting medication. That means the patient can take it once a day. And Prof will talk about this in this much more. We'll expand more on this in the second part of the presentation. And it's also efficacious in patients of African descent and those that are greater than 65 years. And finally, because we know the challenges with our own setting and climb, it has minimal requirement for laboratory testing. DJ, please. So I will just talk briefly on what are the drug treatments in hypertension, the general principles for drug treatment in hypertension. First of all, is the use of low doses to initiate therapy. So generally for hypertension, once you are about to commence treatment for hypertension, you start at the lowest dose for the medication you are going to be using. After starting at that, you need to allow for at least 2 to 4 weeks to assess the effects of the medication you have given to the patient in form of, is it going to reduce the blood pressure, or how much reduction has it been able to do to the blood pressure before you decide to titrate upwards. Now, another thing is the use of long-acting drugs which provide 24-hour protection. Recall I said that one of the reasons why amlodipine was chosen for the Nigerian hypertension protocol is because it is long-acting. So this is very important because we know all the concerns that are pill burden. Patients complain when they have to take medications in the morning, afternoon, and night. So you have to look for a medication that works, that is long-acting for 24 hours, that will permit the patient to take just once a day. Very important. And again, what we're going to talk about today, which Prof will expand more on, the use of 2 drugs for initial therapy, combination therapy, if the blood pressure is 20 or 10 millimeters of mercury above the goal level. So in treating hypertension, there are different target levels. There is the target level for hypertension in the general population, which is different from the target level that you want to get to for hypertension with those with diabetes. So initially, if you meet a patient and upon diagnosis of hypertension, that blood pressure is around 20 over and 10 millimeters of mercury above. Say, let's say you are meeting a patient with a blood pressure of 160 millimeters of mercury for systolic and 100 for diastolic, then you should consider treating that patient on 2 medications. And of course, we are going to look at the use of appropriate drug combinations. DJ, please. So again, we are going to talk about, like I did say earlier, the last thing I said was the use of appropriate drug combinations. Now, there are different classes of medications for hypertension care and treatment. So one thing to note is that different drugs within the same class show little or no differences in efficacy. So if you have two drugs that are in the same medication class for the treatment of hypertension, so what we are simply saying is that you can't use both of them together. One of them would be enough. So most patients would eventually require more than two drugs to achieve control. The use of drugs will provide some other benefits in this setting, and then you also have to consider cost. So the thing to bear in mind today is that you cannot use two drugs from the same class to treat hypertension. So for combination therapy, don't forget that you have to use two drugs from different classes to treat hypertension, not two drugs from the same class. TJ, please. So this, I'll just run through this. This is an evolution of guidelines on fixed dose combinations. So right from 1999, you can see the guidelines released by the International Society of Hypertension, the WHO, the DNC, European Society for Hypertension. Clearly, you can see that there has been a preference for treatment, for use of combination therapy for the treatment of hypertension. So I'll just read the last one, which is the one. It says the guidelines favor the use of combinations of two antihypertensive drugs at fixed doses in a single tablet because it improves adherence and increases the rate of BP control. So Prof will also talk to you and explain what we talk about fixed dose combination and free pill, what we call the single pill combination and free pill. So for single pill, you have two drugs from different classes combined in one tablet, while for the free pill combination, you have the two drugs as individual tablets. TJ? So these are some of the medication classes for hypertension treatment. There are actually more medication classes, but these are the classes that were recommended or contained in the WHO Global Hypertension Treatment Guideline that was released in 2021. So the first one is the calcium channel blockers. I know that some of us have heard of this. So amlodipine, nifedipine, they are examples of calcium channel blockers. We also have the angiotensin receptor blockers, losartan, valsartan, and telmisartan. We have the angiotensin converting enzyme inhibitors, lisinopril, enalapril, and captopril. These are examples of this class. And we have the diuretics, the hydrochlorothiazide, indapamide, clothalidone, some of which are referred to as the thiazide diuretics. DJ? So this is the WHO, the World Health Organization recommendation on combination therapy that's as contained in the 2021 Global Hypertension Treatment Guidelines. So clearly it says that antihypertensive medications, it identifies the classes which we had seen earlier in the earlier slides, the four classes where the combination therapy can be pulled from. It also prefers a single pill combination, like I said, single pill, two tablets combined, two medications, two drugs from different medication classes combined in one pill, rather than having them as individual tablets to improve adherence and persistence as initial treatment. It lists the classes of medications, diuretics, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and the calcium channel blockers, which we have already talked about. So two things to note. It says combination therapy, very valuable when the baseline blood pressure, which we have already talked about, is around 20/10 millimeters of mercury, higher than the target blood pressure. And then it tells you the fact that single pill combination therapy improves medication taking adherence and persistence and BP control. But Prof will talk more about this. TJ? So these are some of the examples of the combination medications that are on the WHO World Health Organization Essential Medicines list. We have the calcium channel blocker plus ACE inhibitors. We have the calcium channel blockers plus the angiotensin receptor blockers. We also have the ACE inhibitors and the thiazide diuretics. We also have the angiotensin receptor blockers and the thiazide diuretics. These are the ones that have been recommended by the World Health Organization, but this does not mean that others are not available. Thank you. So I think I'll hand over now to Prof.
Thank you very much, Dr. Osei, for this very excellent presentation. I want to start by thanking the organizers of this meeting for inviting me, and also the partners for a very beautiful initiative of capacity building in hypertension. And already Adora and Dr. Osei have said the ball rolling, so I'll just continue with the part 2 of the presentation, talking about combination therapy. So already, as mentioned by Dr. Osei, combination therapy just refers to taking 2 or more medication in a single tablet. And it's a recommendation by many societies and many guidelines. So it can be either it can be a single combination, which is a fixed dose. The fixed dose meaning the dose cannot be changed, because if I have a drug that contains 5 milligrams of drug A and 100 milligrams of drug B in a single pill, that particular drug remains fixed. You cannot change the doses. But the good thing is the companies now are doing similar drugs containing similar drug, but in different dosing combinations. You can have a drug, a single pill that contains 5 and 10 or 5 and 5, so that there is flexibility in the therapy of hypertension. And the other one is the free combination, in which the patient takes the medication in 2 different tablets or 3 different tablets. So that obviously increases the burden of the pill he's taken. It's much easier for a patient to take 1 pill containing 2 or 3 medications than to take 3 medications all separately. And the advantages are very obvious that you see later. Next slide. Now, the indications for this therapy has already been alluded to by Dr. Osi, but I will go through them again. When you have a patient that has baseline blood pressure more than 20/10, which is the same as the first one, grade 2 hypertension using the DNC7 is 160/100. And if you just break that down, 160/100 is 20/140/10/90. So it's the same thing as saying that the baseline blood pressure is more than 20/10. So when you do that, it's likely that the patient will need to have 2 drugs to control the blood pressure. The other indication are non-achievement of target goal within a single drug, and the targets are clearly defined by different guidelines. And the treatment with comorbidity, sometimes you have a patient that has hypertension and other comorbidity like angina, like BPH, in which you use 2 drugs that will address the hypertension and the comorbidity. For example, somebody with BPH, an elderly man with hypertension, may require an antihypertensive like amlodipine, because it's good in patients who are more than 65. And also we need a alpha blocker like prazosin or like zazosine or like other BPUs that would also be beneficial in the BPH. So this is another indication. Then the third one, the last one is if you have side effects from a single medication from taking high dose. For example, somebody taking 10 milligrams of amlodipine having headaches or leg swelling. If you can add a second drug and reduce the dose of amlodipine, and that would make the side effects disappear sometimes. So these are some indications that are not exhaustive, but there's some indications. Now, why do we use combination therapy? This on the y-axis, you see that there are several trials that have been done in the past. Each one with the blood pressure achieved in that trial, still blood pressure achieved. The MDRD is a trial, the whole is a trial. While on the x-axis, you see that there are the number of drugs needed to control the blood pressure. And you see that in all the trials, the patients require 2 drugs. These are the 2 drugs, and some in other trials require 3 drugs, and even some trials 4 drugs to achieve the target blood pressure of the systolic outline. So these trials, just about 10 of them, have all shown to us that 70 to 80% of our patients with hypertension will require 2 or more antihypertensive medication to control their blood pressure. And this is a very important information, so that when we are treating our patients, we have that at the back of our mind. We don't stick to one drug, even if we don't achieve target. Once we start with one drug as recommended in the protocol for Nigeria, and you don't achieve target within 2 to 4 weeks, we just add the second medication, because we know most of them require treatment anyway. Next slide. Now, these are the various forms of medication already have been shown in a different way by Dr. Osi, but I'll go through them. You can see there are solid green lines that are shown in this picture. You see, this is combination. This is depicting combining thiazide diuretics with angiotensin blocker. This one is combining ARB with calcium antagonist. This one is combining calcium antagonist with S inhibitor, and this one is combining S inhibitor with thiazide. These are the recommended ones, and a lot of trials have shown that these are effective combinations. There's a trial done in Nigeria that actually have shown that the combination of calcium antagonists, in fact, in Africa, in all of Africa, combination of calcium antagonists with thiazide diuretics are probably the best combination that we can get, and of course, others are also effective. Now, the others, you see that, for example, this red line, we don't recommend combining ACE inhibitor with ARB because they overlap in their mechanism of action. And then this one, thiazide diuretic with beta blocker, can be done, but if you do that, you are doing at the expense of having increased side effects, especially metabolic side effects. So there are several combinations that can be made, but these are the ones recommended by the World Health Organization. Next slide. Now, the advantages of combination therapy, as you will see, is that once you are giving 2 or 3 drugs in a single pill, there is a decreased pill burden. The patient doesn't have to take several drugs at once. So all these drugs are in one pill. So it's either 2 in 1 or 3 in 1. This is really important because the next advantage is the better adherence and persistence. I'm going to define these 2 terms shortly. The other advantage is that you have better and faster BP control, also related to probably adherence, and then better BP long-term control. Because you are using combination, you have the flexibility of using low doses. If you do that, you have less side effects. This is another advantage of combination therapy. And then because hypertension happens through different mechanisms and then different pathways, and patients are different. Each patient is different. And some patients have one pathway predominating over the other, as you see later. So if you give more than one drug, you are addressing different pathways, and the tendency of having control is much better than if you're doing only one drug with addressing only one pathway. And of course, the less it's caused. This has also been shown by evidence, and also there is reduction in cardiovascular events from several trials using combination therapy. So those are the advantages of combination therapy, and we encourage all of us to do combination therapy in hypertension. Next slide. Now, what is adherence or compliance? Adherence is synonymous with compliance. And the adherence is defined as the extent to which a patient acts in accordance with the prescribed interval and dose or dosage regimen. So if you say a patient can take a drug 5 milligrams twice a day, the extent to which that patient adhere or comply to that prescription of taking the drug at that particular dose, at that particular interval, is called adherence or compliance. While persistent, on the other hand, is the accumulation of time from initiation to discontinuation of therapy. For example, if you give a patient a drug 5 milligrams twice a day for a month, and so if the patient continue taking the drug without any break for the whole of that week, or the whole of that month, or that 6 months, or that 1 year, that means the patient is persistent on the medication. You can see that in the other pictures, in the picture at the bottom. This patient with the lower beta has not even started therapy at all. Now, the next patient started, but was not adherent because it was breaking the therapy and eventually becomes non-compliant, stopped the medication. Now, this patient started for maybe for like 6 to 8 months, and at the point remained, stopped the medication and became non-persistent. And this patient is partially compliant because even though he has taken the drug for the whole of the 1 year, but is not adhering to the medication as prescribed, and therefore is partially compliant. While this patient that has the whole bar filled with blue is fully persistent for the 12 months, this one is fully compliant for the 12 months. So this is the difference between adherence and persistence. And what we want to achieve in our patients is both adherence to prescribe medication at the prescribed dose and dosing interval. If you are given the dose that is more than once a day, now almost we encourage patients to take to doctors and healthcare workers to prescribe drugs that's taken once daily because of compliance, and therefore it's not good to prescribe a drug that taken unless it's necessary twice a day. And then so we want to achieve full compliance and full persistence in our patients. Next slide. Now, this is what I was talking about, the various regulatory pathways of hypertension. Now, these are 3 different patients, each one with one pathway predominating over the other. Now, this one is patient 1. You see that this is the yellow is total body sodium, the black is sympathetic nervous system, and the blue is the RAS system. And this is the same for the patient 2 and 3, just interchanging which pathway is predominating. So if you give a drug, for example, the patient 1, while you need the RAS system is predominating, you need RAS blocker in addition to other medication. RAS blocker may not be enough, especially in our population, where the Black population, we know that RAS blockers are not very, very effective as monotherapy, and therefore we need to combine them with either a calcium antagonist or a thiazide diuretic. Now, so this patient needs to have at least a RAS blocker. This patient, on the other hand, needs a diuretic, while this one probably needs a beta blocker. But the issue is it's very difficult to identify without doing very advanced investigations which pathway is predominating which one. So the easiest way is to use knowledge, that is what you knew from trials in various populations, and give drugs that have been best, that have been shown to be best effective in that particular population. For example, in African Black population living in Africa, we know that from the Creole trial that we did in over 9 countries, combination of calcium antagonist and thiazide that is the best combination to give in our population, and of course combination of also of an ARB and calcium antagonist or S inhibitor and calcium antagonist are also effective, as well as combination of ferrous blocker and thiazide diuretic. Next slide. Now, the advantages of this multiple mechanism is that the drugs we give, the components with the different mechanism of action interact synergistically. So these drugs complement one another in controlling the blood pressure. The other advantage is that they neutralize their side effects or the counter-regulatory mechanism. And I'm going to give you one example. And the last one is that the multiple mechanisms result in BP reduction that are additive. So these are the advantages of using multiple drugs that address multiple mechanisms in addressing blood pressure. So you'll see in the next slide how this is exemplified. Next slide, please. Next slide. Now, this is a picture to show you a patient that received. The first one on your left hand is a patient that was given a calcium channel blocker. Now, as a single agent to control blood pressure. Now, this drug has some side effects, not in all patients, but in some patients. One of the side effects is leg swelling or pedal edema. Now, what happens is that this drug dilates arteries. Now, only it does not affect the veins. Now, if the arteries are dilated and the veins remains constricted, there is capillary overload. Capillaries are between the arteries and the veins, and that will push fluid into surrounding tissue and cause edema. Now, if you give it as a single agent, while if you give a calcium antagonist together with an angiotensin blocker as combination therapy, you are giving drugs that dilate both the arteries and the veins, and that will take care of the capillary overload, and the edema will not happen. So in this way, these drugs act synergistically to improve the blood pressure as well as prevent the counter-regulatory mechanism or the side effect of edema in this patient. So this is a clear example of how combination therapy produce a side effect that can happen from a single medication. Next slide. Now, follow-up for hypertension patient is normally for life. There's nothing like your BP is controlled, stop your medication and go home and monitor. We need to monitor the blood pressure, but we need to follow our patient as it's very, very important. And these days we recommend that patients that are enlightened, that can take the blood pressure at home, are encouraged to take their BP at home. Very important, because evidence has shown that those blood pressure measured at home are even more predictive of outcomes than office blood pressure. So encourage your patients to have a notebook, have a BP measuring device, teach them the correct procedure to do the blood pressure at home, and encourage them to take the blood pressure, record them, and bring them along with them to the clinic when they are coming, so that you can see the blood pressure and the control. And that will really help you in taking your decisions, even if they come with pressure that is slightly elevated. If you see the BP is controlled well at home, there may be something that may cause the BP to go up at that point in time, and you will take the decision of changing the drug or increasing the dose. So this is very important. Another issue is you do follow up to change organ function, because BP affects several organs. And lastly is that BP levels are very closely related to outcome, and that's why you need to follow up your patient. Next slide. Next slide. Now, this, I'm not going to go through in detail, but it just shows you that the follow-up and investigation you need to do for hypertension. You can go through, I'm sure you'll have the benefit of having the slides later. There is tests you do when you have a patient diagnosed first time, and then you do them follow-up. So most of the tests are done annually if they are not abnormal. And important to see, to do your analysis for protein, sugar, to check for microalbuminuria, to check for serum creatinine, for kidney function, potassium and sodium. Sugar is very important because diabetes and hypertension occur together often, and also you need to take the blood pressure. ECG is done to take their also screening for heart disorder is very important. And of course, you do other additional investigations as necessary, especially if you suspect secondary hypertension or other things. Next slide. Now, we want to switch gear quickly to talk about resistant hypertension. Now, this is hypertension that is not responding to treatment. But to be clearly defined, is said to be hypertension that is not, you're not achieving targets, your target goal. The patient is on at least 3 medications, including a thiazide diuretic, and has taken the dose for at least 1 month. Now, this is a bit, this is the definition, but if you clear that, so the important things embedded into the definition, because the patient needs to adhere to the drug, you understand, and the drugs need to be effective, right? And you need to take it for at least 1 month or 4 weeks, and at least 3 including diuretics. So this is important, and you need to differentiate this from other nomenclature. Next slide will tell you about uncontrolled hypertension. Next slide, please. And uncontrolled hypertension is not synonymous to resistant hypertension. The issue is people are said to have uncontrolled hypertension when they are not at BP goal, independent of the cause and type of the treatment. So in essence, resistant hypertension is one cause of uncontrolled hypertension, but there are others. Others are patients that have inadequate treatment regimen, because a patient is not treated well, the patient, therefore the BP will not be controlled, or the patient is not doing lifestyle changes, for example, or is taking medications that are concomitant with the, and they're increasing blood pressure, like NSAID, for example. The other cause is pseudo-resistant hypertension. I'm going to discuss it shortly. Next slide. The pseudo-resistant hypertension is when you have a reason for the BP not being controlled, but it's not apparent. The first one is poor BP measuring technique. So if you don't, that's why I emphasize for BP, for home BP, you have to teach your patient how to take the BP at home properly. Even in the hospital, if you don't take the BP properly using the correct technique, you will not take the correct reading. For example, if you take the BP with the patient talking and shouting, the BP will not be correct. And so you need to do that. And if the patient is not adhering to the medication, it's not taking the drug correctly, or you have the patient has white coat effect, meaning the BP is up in the hospital because of anxiety. And to take care of this, you need to check the home blood pressures, or you do what you call 24-hour blood pressure monitoring, the ambulatory blood pressure monitoring. And then the other one, if the patient is adherent, but the treatment is optimal, you're not given adequate doses of the medication to achieve blood pressure control. Next slide. Now, what are the cost implications of resistant hypertension? That the patient will come to hospital repeatedly because the BP is not controlled, and that is cost of transport and other costs, and even cost to employment. The patient will take time off from work at the hospital. There's repeated investigations done. You don't determine why is the BP is controlled, and then the cost of referring the patient to specialists of course, and then the also cost of doing specialist investigation to rule out secondary hypertension, because one of the things that you suspect if you have resistant hypertension is secondary hypertension, and I'm going to mention that later. Next slide. Now, there are causes of resistant hypertension, and then this slide also includes the pseudo-resistant, the apparently one, the first one on the left side. This one. This is non-compliant treatment, white coat, and pseudo-hypertension. I mentioned that. Now, the true resistant hypertension is when you have a patient using illicit drug use, like cocaine and other things, also herbal medicine, we don't know what's inside them, can cause the BP to go up. There are other factors, clinical factors, including obesity, including excess salt consumption, or obstructive sleep apnea. These are all conditions that can cause the BP not to be controlled. Now, the other one is secondary hypertension. That is, the hypertension is secondary to something else. This accounts for about 10 to 15% of hypertension. Majority, 90%, 85 to 90% of hypertension are essential hypertension in which you don't have the apparent cause. And this is what you see in young people or in children. And so you need to think about that, especially if you have a young adult who's resistant hypertension, and investigate to determine whether that patient has a secondary hypertension or not. And the other one is non-identifiable cause of of resistant hypertension. Next slide. Next slide. So when you evaluate a patient with hypertension, you need to do a 24-hour ambulatory blood pressure measurement, and this will exclude white coat. If the patient is having anxiety-related hypertension in the hospital, if you put the cap in their arm and you send them home in the natural environment, and you will not see that the BP persists as high. You feel within the normal limits. That will exclude white coat hypertension. The other one also is evaluate prognosis. The other evaluation is to evaluation of compliance treatment. This is by asking the question and making sure the patient And then the other means, of course, that are used. Now, of course, you need to exclude secondary causes of hypertension that have been shown in the previous slide. And finally, you also need to determine your treatment approach. Next slide. The approach to treatment of resistant hypertension is to confirm that it's true resistant, to exclude pseudo-resistant, to identify lifestyle factors that are contributing to the resistance and reverse them, and to discontinue interference substances like use of illicit drugs, for example, and the screening and appropriate treatment of secondary causes, because if you treat the causes, usually the patient is cured of the hypertension, because the primary cause is having taken care of. And of course, you have to emphasize non-pharmaceutical therapy like lifestyle changes and the use of definitive multi-drug regimens. Usually they require multiple drugs. In any case, even from the definition, you need to they need to be on 3 drugs for at least a month. Next slide. Now, this is probably I think the last slide. So this is when do you refer patient? This is very important, especially for primary care. Now, once you have a patient that comes with a severe hypertension, BP more than 110 or 80 over 110, that patient needs to be referred. Sometimes you need to keep them for a few minutes to take the BP again. Sometimes it comes down because they're anxious or something like that. But if it persists after a few, just refer them to specialist care to be treated. The other indication is if you have hypertension in young people. Young people, even though now these 40 years may not hold, we have people in their 30s, even 20s. You investigate, you don't find any secondary cause. But if you have a patient in hypertension in a young person, think of secondary hypertension and refer them, especially if you don't actually target, to specialist care for investigation. And then once they have heart disease or stroke or transient ischemic attack, they need to be treated by a specialist. And then, of course, when they have heart failure with breathlessness, leg edema, leg swelling, and abdominal swelling, that are symptoms of heart failure, please refer them. The other thing is the ischemic heart disease symptom, new chest pain or change in severity of pain, or somebody with the transient ischemic attack or stroke, please refer them. And then once you have any evidence of target organ damage or cardiac murmurs, and then, of course, when they have resistant hypertension, by definition, need to refer them. Now, I want to briefly, before I close, say that hypertension, we have many guidelines to hypertension. Guidelines are to guide us. But every patient is a different individual, and you need to consider their own circumstances in their treatment. And so the guidelines are not to be followed, they're not cast on stone. You sometimes use your clinical judgment and adjust. And the guidelines, the protocol has been shown by the OC, has been derived by extensive discussion by several experts in Nigeria to achieve that. So thank you very much for this opportunity, and I look forward to the discussion. Thank you.
Thank you so much, Professor Sani. Thank you so much, Dr. Osei. We truly, truly, truly appreciate this. So would give the floor to Professor Mbakwem to give her expert response to this case presentation. Again, please feel free to type in the chat your questions, and feel free to also add your contributions to the session. Over to you, Professor.
Thank you, Adora. Thank you, mDoc. Thank you, Northwestern University. And I want to thank University of Abuja, for inviting me to contribute to this discussion. I mean, hypertension, it's the major cardiovascular risk factor we have in this country. If we can control hypertension, we can control the strokes, we can control the heart failures, we can control the kidney failures, and that it behoves on us to manage the patients properly. And I would like to, kind of impress on everyone here that hypertension is like a moving target. So just attending this, being part of this discussion is not enough. We have to keep learning every day. Sometimes we have to unlearn what we had learned before because evidence has changed, and some other, and there are new things coming on, and we have to be, at the hem of things, and that's the only way we can get our patients properly managed. So if we can go back to the first slide, the one that was presented, the case presentation, so that we can run through. DJ, the first, Nosiforma's first slide. Yeah. Okay, next. So she's giving us the biodata. Next slide. Okay, so this is good. You know, I like the way she started it and all the other things. But you know, and then she talks about no chest pain, no shortness of breath, and no blood vision. But I would have liked, or my advice would be to make the history a bit more extensive, because what we've just ruled out now is the cardiovascular issues and maybe the you know, the vision affectation, you know, of complications of hypertension. But we know that hypertension has so many other organs that it affects. You know, talking about if you're thinking about the brain and the central nervous system, you know, we can go a bit further to ask questions like whether patient has you know, fainted before or has had what the patient will call a mini stroke, whatever that means. But we know that once you've had a TIA, which is what we'll call it in the as healthcare providers, you know, then that means the what we're dealing with is no longer just hypertension, it's now hypertension plus. It's also very important to get the you know, urinary frequency of these patients. Remember that the chronic kidney disease or the affectation of the kidneys, you know, does not start at the end when they have end-stage renal disease. You know, at the initial part of the renal involvement, the only thing that may happen is that the patient is no longer able to concentrate urine properly. And this will be more evident at night, where you find a patient who used to wake up only once at night to, you know, to urinate, wakes up like 3 to 4 times. And then you know, you would want to know whether the urine is frothy, you know, what else is happening to the urine. You know, these are the kind of things that will help you, you know, take a good decision as to what to do with this patient, whether I'm going to manage this patient at my center or I'm going to move this patient on. You know, we heard Dr. C's and Professor Sali's presentation as to what to look out for and all that. But if you don't take, you know, a good history, then, you know, it's like running around in a darkened room and trying to find, you know, an object in that place, which makes it a bit more difficult. Next slide. Okay, so these are all the things we've been talking about. Next slide. So he takes a bottle of alcohol beverages daily. So please, I want to impress upon you, when you take a history of alcohol, also ask for use of, you know, herbal preparations, you know, native medications, because some of our herbal preparations are alcohol-based. So this man may be taking just 1 bottle of alcohol, beer a day, but he's taking one of the alcohol-based native medications. I know those ones are 100% ethanol, you know, so they don't see that as alcohol. They see it as a medication or herbal drink to help, you know, help with their health. But when you put that all together, you find that this man may be taking a lot more alcohol than would have assessed just using a bottle of beer to assess his ethanol intake. Next slide. Okay. Yes, so the man looks healthy, you know, BMI is okay, but please don't just be deceived by BMI alone, because we know some people have a normal BMI, but their waist circumference is out of abnormal. And we know that the fat, you know, that you lay around the trunk, we talk about truncal obesity, you know, that fat around the peritoneum, you know, around the central area is a very bad fat to have. So somebody may have a normal looking BMI, but has an abnormal waist circumference or waist hip ratio, you know, that is also, as you know, is also truncal obesity and would cause, and if not much more harm than the one you assess with BMI. So please don't be deceived by BMI alone. Look at the patient's total physique. And then I want to come to the blood pressure. I don't know whether it is 147/101 or 147/110. But whatever, because in the next slide, it talks about 147/110. Yes, this will be great. Yes, okay. So for the classification of hypertension, we are advised to use the higher level, whether it's the systolic or diastolic, to put the patient in the particular class or grade. So his systolic is in the grade 1. His diastolic blood pressure has moved into grade 2. So if I'm assessing this patient, if I'm using the first reading, I'll move this patient to grade 2 hypertension. And then even if the next slide said it was 147/110, which actually moves him into grade 2, even though his systolic, you know, seems to be in grade 1. And the other thing we need to avoid is the use of terms like mild, moderate, because that's what patients want to hear. Oh, my own hypertension is still mild. But there's nothing like mild hypertension. It's just a grade. And we know that the numbers we measure with the sphygmomanometer does not answer all the questions. So that's why the guidelines, or most of the guidelines are discouraging the term mild, moderate, or severe, and just use the grade or the class. Next slide. Okay, so he was placed on amlodipine. Okay, yes. So as per the protocol that we have been given, that Dr. Ossi discussed, so the facility did the right thing, if that is the protocol they are using. But then, like I said, if they use the diastolic to classify this patient, then this patient should have gone to, stage 2 hypertension and should have had, 2 medications, single pill containing amlodipine and losartan, which is what you have in the protocol, from start. And that shows up, as the case went on, because the monotherapy did not actually control this man. And he went up to 2 medicines and went up to 3 medications at a point in time. So said patient was reassured, alcohol intake, very good, reduce salt intake. Please, when we talk about salt intake, the easiest one to reduce is the one at home. So we can say don't put too much salt in the food. But there are other hidden sources of salt, and you need to find out what they're doing, because some of my patients will tell you, oh, doctor, I don't use salt anymore. I just use Maggi and Knorr cube or whatever, seasonings. But we know that whatever you're using, Knorr cube, Maggi, whatever name you want to call it, it has salt in it. And then the patient, this man is educated, he has tertiary level of education, so he should be taught to read food labels. Even everything around us has a bit of salt, so he should look at those. Even some biscuits, I'm sure we've eaten things like TUC, where you have the grains of salt on the biscuit. So you can't reduce the salt at home and eat all these things and not have a high salt intake. Adherence to DASH diet, very good, but I hope it was explained to him, because sometimes, we talk to the patients as if we are talking to ourselves. We talk all the, technical jargons that patients do not understand. And adherence to medications. Thank you, Professor Sani, for that very wonderful presentation. Adherence to medication. But my point here is, which is one thing I've learned to do with the patient, communication is key. The patients most times do not understand us. The man he just had a headache. I'm sure the headache is gone by now. So he doesn't say the reason for taking this medication. So we really need to talk to them. They need to understand why they need to take these medications, because remember that some of our medications will cause them side effects. So I was okay before you gave me your medications, and now I'm taking your medications. I'm getting up how many times to wee. I'm having all sorts of issues. So and there will be no encouragement to continue the medication. The easiest thing for anyone to do would be to throw the medication away. Okay, so a month later, that's what I was saying. Repeat blood pressure went to 170, 102, because this man was already in stage 2 and we're treating him at stage 1. So that one medication, amlodipine 5 milligrams, did not work. Okay, and then when losartan 50 milligrams was added, and he was seen 4 weeks after. Next slide. And so he admitted to not being adherent. So when a patient, admits to not being adherent, the right thing to do is to find out what the problems are. It may be the timing of the medication. It may be the the side effects of the medication. It may be the cost. So we need to find these things out and not just, sit on our high horses as healthcare providers, and reel out the reasons why he must take his medications. Because we can talk all our grammar, say all we want to say. We're not going to follow that patient home, to make sure he takes his medication. And then Professor Sade had talked about the home blood pressure monitoring. this man is educated, this man is a businessman, so he has, I believe he has the resources to get himself a home blood pressure monitoring equipment. We need to insist on it, and then for them to keep a diary. So that gives us a more holistic view of what the blood pressure is doing, and not just this one blood pressure that we measure once every month or once in 3 months when the person is better controlled and we're giving longer appointments. But we may find that the blood pressure at home, the blood pressure in the office looks normal, but at home is uncontrolled, what we call masked hypertension. Or it could be the other way around. Blood pressure is controlled at home, and then he comes into the office because he knows that Dr. Ossi or Professor Sani is going to shout at him, so his blood pressure goes up, or that the nurse is going to is going to be very mad with him that he didn't do this, he didn't do that. So the blood pressure may go up. But you find that when you look at his records, all through at home, he's had normal blood pressure. So I wouldn't be in a hurry, to adjust his medication at that time. And then on revisit, I'm just wondering what had happened between 2021 and 4th of August, 2022. Did he stop his medication because we moved from C2 to this very high uncontrolled blood pressure? And then in the presentation, we didn't hear about basic investigations that were done for this patient. Yes, we're told that he's not diabetic, but a fasting blood sugar, which you can get in most of our PHCs with a glucometer, a urinalysis that will tell us how much protein this man is, if he's feeling protein in the urine. And of course, for the more equipped facilities, getting a renal, the urea electrolytes and creatinine of this patient, getting an ECG done. Those are basic investigations that will help you class this patient, properly. At this point in time, this is 210, 135, and 218 over 135. So I just want to take a poll here. How many people think that this man has become resistant hypertension? How many people on the call? Is it possible, Hadora, to ask this? Hello? Can anyone hear me?
Yes, it is. It is possible. So please type in the chat in response to, again, remember, we're trying to make this as interactive as possible. So, or you put up a thumbs up or thumbs down. So she said, how many of us think this patient has moved on to having resistant hypertension? Give us a thumbs up or a thumbs down quickly in the chat. Let's do this very quickly.
Very quickly, yes.
Or you can say yes or no. Okay, so I see some answers.
Okay.
We're seeing many thumbs up. We're seeing many thumbs up.
Okay. Okay. So that's interesting. That's interesting.
There are some people that are saying no. We see some no's as well.
So what's it like? Who is winning, the yeses or the no's?
At this point, it is the yeses, actually.
The yeses.
We have fewer no's.
No's, okay. But I'm sorry to disappoint the yeses. I'll vote with the no's. We had the definition, resistant hypertension. So the patient needs to be on 3 medications at maximum doses, one of which must be a diuretic, and must have been taking them consistently for about a month. Okay, so this person is just on 5 milligrams of amlodipine and 50 milligrams of losartan. And then we've had issues with adherence. Remember, Professor Sani had talked about pseudo-resistant hypertension. So this is uncontrolled hypertension, but I wouldn't label this resistant at this point in time because we haven't even hit the maximum doses of what we need to do. We haven't even added a diuretic. And that shows up because at the point the amlodipine was moved up, the losartan was moved up, and a diuretic was added. Next slide. So you can see at his last visit, the blood pressure has actually dropped, even though we still have a bit of a systolic bump here, and then 137.87. So that was, that's what the 200 and something is a pseudo. It's not resistant hypertension, is uncontrolled hypertension, but maybe because we're not giving enough, one of the reasons we're not giving enough medications, and even the little we're giving, patient is not adhering to it. And then when I have patients hit this kind of blood pressures, I really need to check out their renal function, because they are the ones that, you know, run this kind of crazy blood pressure. Somebody steps into your clinic, blood systolic is 250, diastolic is 140. You know, check their renal function. And a simple thing you can do in your place is do a urinalysis. If you don't have the facility to do a proper, you know, creatinine clearance or renal function, you know, test, you know, that will give you. And then if questions about facial puffiness in the morning, you know, that disappears as the day goes by, leg, you know, bit of leg fullness as the day goes by, it disappears, you know, they're passing a lot more urine at night, the urine foams in the WC, you know, those are the things that will give you, you know, pointers, you know, to what is going on. But this man will still need to do a lot more, then look at his salt intake, look at the, you know, then, you know, counseling for any time he comes into clinic, you know, we need to repeat, you know, make sure he's on the same, we're on the same page and he's bringing in his notebook for review. Can we unshare this and share the other slides? I just wanted to point out a few things and then I'll close.
Which of the slides do you? Yes, you can.
Can I share myself? Okay.
Yes.
Okay. Okay, so I just put up this to help us, you know, just to, you know, buttress what we've been saying about, you know, the control of blood pressure. So we know that, you know, so talking about whether mild, whether moderate, you know, I was saying we shouldn't use mild, we shouldn't use moderate, we would just say, you know, the stage or the grade. You know, this is a meta-analysis of 61 prospective observational studies. And what did it show? You know, that once your blood pressure goes above 115/75, your risk, you know, begins to double. So from 115/75 to 135/85, you have 2 times the relative cardiovascular risk as a patient who has 115/75. By the time you get to 155/95, you know, it's 4 times. By the time you get to 175, it's 8 times. You know, so it's a straight line curve. The higher the blood pressure, you know, the higher the risk of CV events. There's really not that blood pressure where you can say, you know, there's nothing is going to happen. So it's not right to give the patient that kind of, you know, comfort that, oh, your blood pressure level is mild. Mild, is it mild as in numbers or mild as in relative risk of cardiovascular events or disease? And this is, you know, for every 20 to 10 millimeter, 20 millimeter systolic and 10 millimeter diastolic increase in blood pressure, there's a doubling of 10-year cardiovascular mortality, whether you are elderly, very, very old, or you're in the 50s, it's a straight line curve, whether you're looking at the systolic blood pressure or you're looking at the diastolic blood pressure. So what I'm trying to say here is, let's not just focus on the numbers, and let's just, you know, cage ourselves into those, you know, straight jacket of it is mild, it is moderate, it is severe. Everything needs to be put into context, you know, into perspective. So apart from the blood pressure, all the other risk factors, all the other baggages the man is bringing on board, you know. And if you look at this, this is from the ESC 2018, you know, guideline. So the man who has a 140/159, this is where you have put, Nosegu has put her patient. This patient may even be at a higher risk, you know, than the man who has 160 to who has 179/110, because we need to factor in the risk factors, whether he has 1 or 2, whether he has 3 to more than 3, whether he has already developed, you know, cardiovascular disease, target organ damage, or he has diabetes, or he already has CVDs. So this person who even has a normal looking blood pressure may be at a very high risk of CV events. So these are grade 1. So if I'm telling him he has mild and there are other things he's carrying along with him, I may be doing him a disservice, because he may be at a very high risk. So the point is, please don't be number centric. Don't just look at the number. The number is good, but put everything, you know, into perspective to decide, you know, where this patient is. And please, please, please don't use mild, moderate, or severe for the patient. Just tell them the grade if you need to tell them that. we've heard about all this, and I was thinking about the the one pill, so everything is one pill, and then two pills. So it makes for better adherence. It makes for better control, reduction in side effects, because you're using smaller doses, to do what you need to do. And then when we get to resistant hypertension, but remember that before we got here, there's ACE or ARB plus CCB plus diuretic, which our patient was not on. And that is why we didn't put him in the resistant phase at that important time. And you saw that as soon as we added the diuretic and increased the doses of his ARB and his CCB, the guy, the blood pressure was better controlled. Thank you for listening, and I'll be ready to take questions and comments.
Thank you so much. Thank you so much, Professor Mbakwem. We truly appreciate this. So because of time, we're going to try to rush through the questions. I will ask them in groups so that we can answer them very quickly, so that we still have the post quiz. So please don't go. We have the post quiz. We've learned a lot, so I know that everybody's going to be able to answer the post quiz without any struggle. So I have a question here. The question is the MRI in the definition of resistant. What does the MRI in the definition of resistant hypertension mean? Do you want to take that, Professor Sani?
MRI.
Yes, so the question says, what does the MRI in the definition of resistant hypertension mean? DJ, do you want to pull up the definition of resistant hypertension so that everyone is clear in case there is a mix-up?
Yeah.
And then someone says, I am an advocate of the single dose combination medication, but my reservation is that many of the brands are quite expensive, defeating the WHO purpose. So that's someone's comment. Any thoughts on that as well?
Now there are generics, there are many generics combination therapies that are quite reasonably cheap and effective. And we use them and we see results. And I'm sure Professor Mbakwem will have something to add on this. So it's not all in the exclusive.
And then, I mean, if you shop around, you can always find the, except if you're going for the branded, then of course you're going to pay the price for the branded cost. Okay, it's MRA, it's not MRA, not MRI. So
MRA.
MRA.
I think it was a typo.
Yes, the other thing I wanted to say before I forget, I noticed that the protocol had calcium channel blockers, and it had amlodipine and nifedipine. Please, if you're going to use nifedipine, use the long-acting nifedipine. The short-acting nifedipines are not good because it causes rapid swings in blood pressure. They reduce the blood pressure very drastically, and then all the counter-regulatory hormones are activated, and the blood pressure goes up and it comes down again and it goes up, swinging around the whole place. Okay, start with amlodipine. Okay, sorry. Okay, so amlodipine, fine. I thought there was one place where I saw nifedipine, but if you're going to use a nifedipine, there is nifedipine like the nifedipine LA, XL, not retard. Retard is a short-acting medication and needs to be given multiple times.
Sure. So I will take 2 more questions and one comment.
MRA,
sure, please go on, sir.
Yes,
please.
MRA stands for mineralocorticoid receptor antagonist. Mineralocorticoid receptor antagonist is a class of medication, and the typical example is spironolactone. So actually, in the case of resistant hypertension, it's now the 4th drug, because you need to be on at least 3 drugs, including thiazide, and then you add the MRA at the 4th drug to treat the resistant hypertension. And this is based on a trial that was done and showed the efficacy of that drug in treating patients with resistant hypertension. Thank you.
Thank you so much. So 2 questions and a comment, and then we will have to go to the post quiz. The question is, please, does this mean that monotherapy is not advisable?
I noted that also in the chat box. So as you see from the discussion, we said that every patient is different. In the protocol, the recommendation you start with a monotherapy, which is amlodipine 5 milligrams. But if in practice, there are patients that you see them, even with a blood pressure of 150 over 94, for example, you will still want to start them with more than one medication. So it's not it's not contraindicated. We still do it, but just not that most patients, you see in this example that was presented, will require more than one drug. Patient comes with blood pressure that is in the grade 1, in the high end of the grade 1, already has a loud A2, already has things come with the result as LVH. So that patient is very likely to respond to a single medication. So you have to assess the patient, as mentioned by Professor Abdul. Every patient should be assessed on his own merits. That is the bottom line. I also said that these guidelines are not cast on stone. You must follow them all through. You must weigh and look at the patient and then treat them. But it's not contraindicated, but not that most patients will require more than 2 drugs. So the 2 drugs or more require really control. Prof, we can add something.
I totally agree with you. But I mean, before we can say that monotherapy, it means you have fully evaluated this patient, and there's nothing else in the background. Only this this blood pressure elevation that is in that stage 1. But please watch that patient, because in the next 1 year or how many months down the line, that patient may need another medication, because that's what studies have shown, that even those that start monotherapy over time will need more than one medication for good blood pressure control. But please evaluate the patients properly. Sometimes when I sit in clinic with my students, they're wondering, this person comes with 140 over 90, goes home with 3 medications. The same 140 90 goes home with 1, the other one goes home with 2. So it's as if we're throwing calories, but it's because of real evaluation. So that 140 90 may already have LVH, has ECG changes of maybe ischemic changes on ECG. So I'm adding a beta blocker. I'm adding some. By the time he's leaving me with this 140 90, he's going with about 3 medications, and you're wondering why should that happen? But it's just because we properly evaluated the patient.
Wonderful. The last question: what are the contraindications of thiopurine?
So thiopurine is a combination of ramipril and a thiazide diuretic, right? So you take the drugs individually. For example, the ramipril is an ACE inhibitor, so it's contraindicated in patients who are allergic to it, patients who are pregnant, patients who are breastfeeding, patients who have angioedema, documented previously. So these are the same side effect contraindication. While the thiazide diuretic, patients who have gout, for example, or for this lipidemia now, if you treat it, we don't really care, because the side effects is hyperuricemia, dyslipidemia, and other things. Of course, if they're allergic to also, you don't get it. Then electrolyte problems like hypokalemia or side effects. So look at the side effect of the drug, and look at the patients who have tendency to have the side effects, and you avoid the drug as much as possible. So thiopurine, just look at the components of it, and look at the contraindication of the individual drugs, and then address them as it is. Prof?
Okay, so the other thing I wanted to add, this patient had to get 25 milligrams of hydrochlorothiazide, and this is where when the metabolic side effects begin to show up. Most of the single pill combinations we use 12.5 milligrams of thiazide, but we can use, if you have the opportunity to use the thiazide, like things like indapamide. They have less metabolic, derangement, and are tied to them, as opposed to these other things. And the other thing I like about indapamide is about the reduced effects on sexual function in men. Please let's not throw that away, because a lot of our medications will cause, erectile dysfunction in men. And remember that these men you're treating don't have any complaints at all. They didn't have any issues at all. And then you come with your medications and the man can no longer perform. I mean, the most logical thing to do is throw away the medicines that is causing this problem. And in doing that, we'll now end up maybe getting them in the emergency room when issues have happened. And please, 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 in all we do, let's treat these patients with a lot of, understanding. And patients will take a drug holiday. Don't kill them. I mean, if I take a poll, just that we are run out of time. If I take a poll of the doctors on this call, I'm not sure any of us has ever finished. There'll just be a few of us who finished a course of antibiotics. The healthcare workers here. Then somebody who doesn't have any symptoms, day in, day out, they open their mouth, they're popping pills, and the pills are giving them side effects. So please try to be a bit more understanding. And you know, the worst patients, prosthetic and everything, the worst patients we have are the doctors and the nurses and all the healthcare workers. When you have them as hypertensive, they are the patient that will run you up the wall.
Thank you so much. So we will have to stop here. Thank you for such a rich conversation, breaking this thing down to very easy, digestible bite sizes. We truly appreciate it.